So I am going to kind of kick things off and share a little bit more about how we're going to spend our time together. Next slide. We'll start with a look at a hospital-based caregiver program at Mayo Clinic. Then we'll hear about the work at the University of San Francisco, at University of California at San Francisco, excuse me, to increase awareness about Medicare's billing codes to support caregiver training. And after that, we'll hear about the Michigan Caregiver Navigation Toolkit, which is a great resource and example of how health systems are working to standardize caregiver support. And we'll wrap up with a Q&A session. So feel free to drop your your questions into the Q&A box at any point, and we'll make sure to get to them towards the end of our time together. Also, if you're interested in learning more about our speakers, you can find their bios in the registration link. So before we jump into those examples, I want to take a moment to ground us in the bigger picture. Next slide. At the National Alliance for Caregiving, we focus on driving system-level change for the 63 million family caregivers across the country through research, advocacy, and shifting how caregiving is understood and valued. And a big part of that work is making sure that caregivers are recognized as part of the healthcare team and not just as informal supports operating in the background. Because the reality is that caregivers are essential partners in care delivery, but their identification, assessment, and support is not always prioritized in our healthcare system. Care delivery still largely focuses on the patient's immediate clinical needs, while the caregiver's own health, readiness, and capacity to provide care for them is often overlooked. And that's where our Cancer and Transplant Caregiving Collaborative come in. These cross-sector initiatives bring together health systems, researchers, and patient advocacy groups to move from caregiver recognition to action and support. And through this work, we're helping surface where the gaps are, what's working on the ground, and what it takes to build caregiver support. And most importantly, this is something that caregivers themselves are asking for. Next slide. Based on our Caregiving in the US report, we know that about a third of family caregivers say they want policies that require healthcare providers to assess their own needs, to ask them how they're doing and what are the needs and supports that they need in order to provide care. So there's both a need and a readiness for change. The question isn't whether we should integrate family caregivers, but it's how do we build and expand the system to do it well. Next slide. And when we look at what caregiving involves, it's clear why this matters. Most caregivers are actively monitoring their loved one's condition, and more than half are taking on medical or nursing tasks at home. Yet only about 1 in 5 receive any sort of formal training to do this. And so we end up with this mismatch where there's a high responsibility and caregivers shouldering a lot, but there's inconsistent or missing support for them to be able to provide that care. Next slide. As one caregiver described it, it can feel like being thrown into a job that you didn't apply for, with no training, no pay, and no support. And this is exactly the experience that we're trying to change. Next slide. Because the no support has real consequences or inconsistent support, has real consequences for the caregiver's own health and well-being. In fact, we're seeing high levels of physical strain, emotional strain among family caregivers. Again, these are stats from our Caregiving in the US 2025 report. Next slide. So Jan's story captures what so many caregivers feel but rarely say out loud. The weight of being someone's safety net, especially from a distance, when your loved one, your care recipient, is hundreds of miles away and something goes wrong. This helplessness can also is not only emotional, but it could also become physical. And this is why we need systems that caregivers can actually reach out to that are asking about caregivers' health and wellness, not just that of the care recipients, but what do caregivers need to sustain themselves? And so as we listen to the experiences like Yan, it is clear that the next question that emerges is what would actually help caregivers feel more supported? Next slide. And the good news is that caregivers are really clear about what they would like for help. They're asking for support managing stress, the emotional toll of caregiving, guidance on keeping their loved ones safe at home, help navigating the systems, and better care coordination. So the need is definitely defined. The opportunity is how do we build supports into care delivery and make the system work for family caregivers. Next slide. The last point I want to make is that caregiving is deeply fulfilling for most people, but it's not sustainable without support. If we want to keep patients out of hospitals and thriving at home, we have to invest in the people making that possible. Sustaining the caregiver is sustaining the care. And that's what today is about. You're gonna hear from leaders who are directly testing, implementing, and disseminating ways to support family caregivers. So with that in mind, I'm really excited to turn it over to Dr. Joan Griffin from Mayo Clinic, and she's going to walk us through their inpatient caregiver program, including what they've learned about implementation, feasibility, and impact on both caregivers and the care team. Joan, with that, I hand it over to you.
Thanks for that kind introduction and for the opportunity to present to the group today. I'm excited to share insights for our caregiver support program and some of the strategies we've used to promote caregivers into care delivery. Let's see if we can move to the second slide in my deck. Yeah, the next slide, please. So this work started just before the COVID pandemic and has been going on ever since. And it really started with a qualitative study that we conducted at Mayo Clinic that aimed to better understand from the perspective of nurses and physicians, both in inpatient and outpatient settings and across different medical specialties, how do you integrate caregivers into the point of care? Some of the themes of today's session. So when we did this qualitative study, in the first half of the interview, we asked participants about their perception on the value of caregivers being engaged in care delivery. And there was a consensus that caregivers are important for providing high quality patient care, that they provide a thorough history, they help buffer challenging news, and they provide an extra set of eyes and ears for health information and care planning. However, when we switched the interview questions towards what they thought was important for assessment, we found more ambiguity. First and foremost, providers were concerned about time. They didn't have workflows that allowed for any kind of assessment, and the extra work that it would take for them to assess, they felt, was diverting attention away from patients. When we began to dig in a little bit more, there was also concern about how they would assess caregivers. And if they formally assessed caregivers, they didn't feel that they had vetted resources to provide or adequate support to provide to the caregivers. So instead of asking about caregiver needs, either formally or informally, the default was to do nothing. So as this work finished up, we really sat down and tried to determine what our next steps would have to be to address some of these issues that Yadira already described in detail. And what we came up with is that any kind of system that we developed for supporting caregivers couldn't interfere with workflows. It would probably have to run in parallel with existing workflows, and it couldn't take up staff time in order to work. So we started looking for models where this might happen and found the Ken Hamilton Caregiver Center at Northern Westchester Hospital in New York. They have an inpatient support program. It's been around for 20 years and it's been replicated in over 25 hospitals. So what we felt that we could use their model and tailor it for Mayo Clinic settings. It also put us on the path towards providing inpatient care as our first step. So the next slide, please. So in 2021, we developed this pilot caregiver support program, and the program is primarily a volunteer-driven model of support and based on the concept of peer support and connection rather than on clinical assessment and intervention. Our team includes 2 social workers who work with our volunteer services program, and they identify and train the volunteers who work as the peer supporters. The volunteers are trained in empathetic listening, resource navigation, confidentiality, unbiased support. And then after they're trained, they round on hospital floors. And they started off by just identifying caregivers by simply knocking on the door of hospitalized patients, notifying the caregivers that were sitting at the bedside about the support program, and asking if they'd like a break to talk. And I will tell you that I was a skeptic about whether this was going to work until I went to the Ken Hamilton Center and saw it in action. And after I visited there and saw what they were doing, I hoped that it would work at Mayo Clinic, but that was the impetus for doing this as a pilot study. So the next slide, please. So with the development of the program, we decided that we wanted to wrap an evaluation arm around the pilot in order to determine, 1, if it was feasible, 2, if it was acceptable, and 3, would we be able to show any preliminary effectiveness on improving care quality. We used an interrupted time series where we collected data from hospital staff and caregivers of hospitalized patients prior to the program's launch, and then collected data from caregivers after they had had visits with the peer support people, and then from staff 1 year after we launched. So we started on 2 hospital units at Mayo Clinic, Arizona, and those units mostly served patients undergoing solid organ and bone marrow transplants because we knew that in order to be eligible for a transplant, you had to have a caregiver listed and present. And the likelihood that a caregiver would be at the hospital and at the bedside was higher so that they would be available for peer support. So the next slide, please. So many of the outcomes and the measures and the results are published in our paper, and I have the citation available on the next slide, and I think that NAC included that as well. So I won't spend a lot of time on this information, since I know the theme of the presentations today and probably what's of most interest to people is to try and figure out how we got this done. So suffice it to say that we really wanted to find out if this type of program could fly, if we could actually identify, train, and keep volunteers, and if caregivers actually found it helpful. We also wanted to know, however, that if the staff thought it was helpful to them, if they thought it was going to be helpful to patients and families, and if we got in the way of their interrupted workflow, or if we interrupted their workflows just based on the qualitative work that we had done previously. So the next slide, please. So for feasibility, we wanted to understand whether it was actually going to work. And what we found is that caregivers were willing to participate. We saw in the first year, we saw 253 care partners, and that was with the 2 social work managers and I think maybe 2 or 3 volunteers. We had a small group of volunteers that grew over that first year. We had a lot of contact hours with people. Our meetings, our volunteer meetings lasted sometimes 2 minutes, sometimes 2 hours, 2.5 hours, but the average was around 20 minutes. The most important thing on the volunteer side is that we had a 0 attrition rate in the first year of the program. So those that we trained in the first year of the program stayed on. That told us that we could actually identify the volunteers and keep them engaged and in the program for a while. We also assessed staff acceptability, and we found that half of the staff reported that they had engaged with the support program and that they had an increased knowledge about support services available to caregivers through the caregiver support program. We also found that they had more confidence in meeting caregiver needs a year after the program launched. Caregivers found that the program was incredibly helpful. So 96% or 90% reported that it was very to extremely helpful to have received a support visit from the caregiver support program. Care quality was a little bit harder, and these were preliminary data. We were not powered to really look at these differences, but we did see a trend towards a reduction in staff burnout and depersonalization. I will mention that this was towards the end of COVID, so there are a lot of confounding variables with that too. And we didn't see any differences in the compassionate care that staff felt that they could provide, or caregivers' ability to communicate better with staff, or their preparedness for caregiving. Let's go to the next slide. So what is the status of the project now? Well, we've moved to a hospital-wide implementation after doing this evaluation component. We have received some ongoing support from benefactors, which has allowed us to sort of expand some of the support that we have, especially for those at high risk, financial high risk, for the caregivers who are meeting some of the financial strain issues. And it has put us on a path for planning a comprehensive caregiver support center that would include expansion of this caregiver support program, the peer support program, to other sites in the Mayo Clinic system, as well as coordinating with complementary services, including our online support programs, palliative care support services, and through cancer education. So next slide, please. So I think the big question that comes up is, how did you develop this program? We know that caregivers are grateful for the opportunity to have time to unpack their emotions. Many have layers of grief, stress, strain, and they verbalize gratitude for being able to say things that they weren't necessarily able to share with their families or with the patient. So this was a neutral person that they could share this with. They were also incredibly happy to have in-house support just down the hall, and if we stepped out of the room, they could be back at the bedside in less than a minute if they needed to be. We also found that patients were relieved to know that there's support for their loved ones, and even when the caregivers verbalize no specific needs, they're pleased to know that there was somebody there for them, or that we offered services that they might need in the future. Let's go to the next slide. So how did we begin to develop this program? We first developed a steering committee that included a lot of our stakeholders. On that steering committee, which still exists today and still guides and is our guiding light for this program, we had representatives from the Office of Patient Experience, we had physician champions, nurse champions, representation from social work, chaplaincy, and of course volunteer services, which is where we drew our volunteers from, and care management. Next slide, please. We also did a lot of work around stakeholder engagement with practice leaders. So prior to our program launch, and we made efforts to spread awareness and to upper level management, physicians and administrators, to get their buy-in and support for the program. We did presentations to various committees within the hospital prior to our launch date. And in addition to the high level buy-in, we also wanted to make sure that there was awareness at the unit level prior to the start of the program. So to this end, we met with nurse managers, team leads, unit-based leads to address nursing concerns. And we did the same with the unit social workers and case managers and chaplains to make sure that they understood this as an opportunity to learn more about the program and ask questions and really understand where the scope of practice was with them and where the scope of practice was with the caregiver support program. We allowed them to ask questions, and they provided us some guidance on how to overcome some stumbling blocks. We also wanted to make sure that we weren't stepping on anybody's toes, and that we made sure that they were aware that we understood that there were boundaries, and that those boundaries really were around patient care. Anything having to do with patient care was out of the scope of the caregiver support program and would go back to the clinical team. So then we also sent email introductions right before we launched. So we really wanted to bring them along as we sort of were in our planning stage. So let's go to the next slide. As we were developing the program, Lynn Battagliano, our amazing social work manager, developed a training program along with our training programs educators, and our volunteers learned in the classroom first. They had 8 hours of classroom training. They really learned about the scope of their role. They learned more basic communication and advanced communication skills, and about some of the resources that we had available for both caregivers and for self-care. They then moved, after the classroom training, they moved to the floor where they did a lot of shadowing with our social work managers, and they did a lot of watching how they interacted with caregivers, and then they debriefed after. And this training was ongoing until they felt that they were comfortable managing some of those interactions themselves. But we did continue to do the debriefs with the social work managers in case there were any problems that came up that the social work managers would pick up. So we had a warm handoff in case there were any ongoing issues. And they do have ongoing monthly meetings as well. So that's the volunteer training. Let's go to the next slide. And as I think I mentioned, we did some phased improvements. So the evaluation was originally with 2 floors in the hospital where we launched the program. We did this evaluation, and then we assessed what the results were from that evaluation. What we found is that we didn't see as much engagement with staff on the units as we had hoped that we would, because we had put up these really clear guardrails of not interfering with workflow. But what we found after the data came in and we talked more specifically to the unit staff, is that they wanted to engage more. And so they didn't see it as an interruption. They saw it as a benefit to them. So we made some changes to the training. We made some changes to the way that we engaged with unit staff when we started to do rounds. And then we tested those new modified procedures out on a 3rd floor, and then tested those for 7 months. And then we went to a system-wide implementation for the whole program across the hospital. That way it was well vetted across, all the changes were well vetted. Okay, let's go to the next slide. So I know many will see challenges to implementation, and we certainly had them. The biggest one probably being the boundary between making sure that everybody understood the boundary between patient care and caregiver support. It can be tricky to navigate, and we emphasize that anything about patient care goes back to the patient care team, and volunteers work with social work managers to navigate this. Another one that comes up a lot is we do not chart in the patient's EHR. So there are challenges inherent in ensuring that the patient care team knows that we are following certain caregivers that were involved and that were available without breaking confidentiality. So we often do a check-in, say they've been seen, but we don't really necessarily share anything that was discussed during those meetings. The third one is around staff buy-in. This was much easier than we would have thought with the RNs. Once they knew who we were and what we were doing, they were by and large all on board. We've found it to be very important to be proactive and forthcoming, to introduce ourselves on the unit. We found that through our evaluation. So now the volunteers go and check in with the unit staff to see if there are caregivers that they would like us to see. We are also open to referrals where nurses on staff or any kind of staff member who sees a caregiver in distress can call our program and get a referral right away and be seen by a volunteer. Space is another big issue. Space, probably like many of the other organizations involved, space is at a premium, so we don't have a physical space for caregivers. So when meeting with caregivers, there are quiet rooms, but again, these are shared with the practice, so there's no guarantee we will have use of them. This can be a challenge because we want caregivers away from the bedside so that they can be completely open and honest. But we also want some place that's confidential and comfortable where they feel free to speak. So hallways and corridors are often not conducive to this, but it's sometimes where we end up. Finally, retention of volunteers is always an issue. After 1 year, as I had mentioned, we didn't have any attrition, but we have seen our share of injuries and illnesses and long breaks with the volunteers. We do request a 1-year minimum, but overall, I would say that retention has been pretty high. If you can go to the next slide, and I'll just finish up here. I want to acknowledge our amazing staff. This includes our program staff, our advisory team, our research team, and all the people who have helped make this work. It's really been a group effort and a lot of really committed people who want to make this work. So with that, let's go to the next slide. I will leave it to the others. If you would like to follow up and talk about this more, or talk about how this might be applicable to your own program or to your own hospital setting, let me know. I'd be more than happy to have a conversation with you and open to follow any questions via email as well. So very happy to do that. I know that's a lot in a short period of time. So thanks for your attention. With that, I'm going to pass it on to Josette, who's going to present her program at UCSF.
Thank you, Joan. Can we advance the slide, please? Hello, so my name is Josette Rivera. I'm a geriatrician, so a practicing clinician at the University of California, San Francisco. And I'm also the PI for the Caregivers as Partners in Care Teams program, which is a national initiative funded by the Administration for Community Living, which is focused specifically on integrating caregivers into clinical care teams. So this session is a little bit different. It's designed to be immediately actionable, whether you're a clinician, a practice manager, or someone working in the aging network. Next slide, please. So just by way of background about our program, Caregivers as Partners in Care Teams, or CAPCT, again, its aim is to educate health and social care professionals to include family caregivers in the patient's care journey with the framework of identify, engage, and support. And to that end, we provide free live and on-demand online training and resources, again, for healthcare teams and the aging network, in alignment with advancing the Administration for Community Living's national strategy to support family caregivers, Goal 2. Next slide, please. So in our brief time today, I'm going to cover 2 sets of Medicare billing codes and give a high-level overview of why they matter, how to use them, and how to navigate the billing guide resources we created in partnership with ATI Advisory that describes their use cases. Next slide, please. So this is a little bit of alphabet soup, but why do these codes matter? So first, to define, CTS is Caregiver Training Services, CHRA is Caregiver Health Risk Assessment, and HRSN is Health-Related Social Needs. So as already been well described, caregivers provide enormous support to patients every day, but for most of Medicare's history, there's been no formal billing mechanism that really recognized their involvement. And so the CTS and the CHRA codes try to change that by creating a formal Medicare fee-for-service mechanism where the services we provide to support caregivers are billable and reimbursable. The health-related social needs, or HRSN codes, address a related but different gap. So rather than training the caregiver directly, they allow providers to bill for addressing the social and economic factors that affect a patient's health. So those are things like housing instability, food insecurity, difficulty navigating the health system, etc., that caregivers are frequently managing on the patient's behalf. So again, these are 2 different tools with different targets. CTS and CHRA put the caregiver as the center of the direct recipient of services, and the HRSN focus on the patient's sort of upstream social needs in which the caregivers may be involved in managing. And again, before these codes existed, even when providers were doing this work, there was no mechanism to capture it or to receive reimbursement for it. Next slide, please. So to unpack these a little bit more, what are CTS and CHRA codes? So again, these codes enable healthcare professionals to directly train and educate the caregivers and to assess their well-being. So the caregiver is the recipient of the service, which is furnished to help the caregiver carry out the patient's treatment plan. So there are 2 qualifying questions in order to bill these codes. First is, does the caregiver need support to carry out the patient's treatment plan? So this connects the caregiver's training directly to a documented clinical purpose. So it's not enough that the caregiver is simply requesting the training. We have to make sure to document that the training is tied to a specific plan of care. Question 2 is around provider eligibility. So eligible providers are physician, non-physician practitioners is listed here, or authorized auxiliary personnel, which are people billing under the direction of a physician or an NPP, which is good news because it expands the practical workforce of people available to deliver these services. Next slide, please. So what do they cover? These codes cover 3 buckets of caregiver training and a caregiver assessment. In brief, the behavior management codes cover situations where the caregiver needs guidance on how to respond to and support a patient whose diagnosis affects their behavior, such as supporting a patient with dementia. The functional performance codes are relevant when the caregiver needs to help a patient with daily activities like getting dressed, moving safely, and these are applicable especially in the rehab type settings. Direct care strategies and techniques apply when a caregiver needs to learn hands-on clinical skills such as how to prevent pressure ulcers, how to treat an existing wound or pressure ulcer, infection control, etc. And then all the way on the right, the caregiver health risk assessment is different from these other training codes because it focuses on assessing the caregiver's own health using validated tools such as the Zaret-Burton interview and the Caregiver Strain Index as just some examples to assess the caregiver's stress and well-being. And I think that these buckets or categories of codes align really well with the things that caregivers are asking for and need that were outlined in Idara's presentation. Next slide. So in brief, who can bill? Again, physicians, non-physician practitioners, authorized auxiliary personnel. Some other types of healthcare professionals can also bill directly for certain of these codes as listed here. And essentially, the first thing is patients must give consent for caregiver training, and there's no specific form required, but you just have to document that the patient gave permission to train the caregiver. Another requirement is the patient is not present during the caregiver training. There's no limit on how many times these codes can be billed, and all of them are eligible for telehealth. Next slide, please. So the HRSN codes, again, they're a little bit different because they focus on when healthcare professionals help to address the upstream drivers of a patient's health. Again, these are social and economic kinds of conditions, and these are factors that caregivers may already be responsible for managing on a patient's behalf. So the 2 qualifying questions to consider as you get started are just recognizing, could the patient have these upstream drivers limiting their ability to be diagnosed or treated for the conditions for which you're seeing them? And then second, again, same as before, is the service being provided by a physician, non-physician practitioner, or authorized auxiliary personnel? So both of these questions have to be yes in order to use these codes. Next slide. So what these codes cover are 4 categories of services. And just in the interest of time, briefly, the community health integration addresses non-medical barriers to care. So things like care coordination, health education, health system navigation, patient self-advocacy. The principal illness navigation focuses on things like helping the patients understand their diagnosis and navigate their treatment pathway, which includes referrals to community-based services and behavior support change. The peer support is around patients receiving navigation support from people with lived experience, and such as certified peer specialists or patient navigators. And then finally, a physical activity and nutrition assessment, which can be billed when the provider does a standardized evidence-based assessment of physical activity and nutrition, and it's payable only when both components are assessed or when only one is clinically reasonable and necessary. Next slide, please. So similar to this, the other codes, the billing and documentation essentials, so similar lists of who can bill. The difference between the HRSN codes and the CTS-CHRA codes here is there has to be an initiating visit, such as a regular E&M visit, an annual wellness visit, some kind of initiating visit before the HRSN services can be billed. And this initiating visit must be performed by the same billing provider who's going to bill for the subsequent HRSN services. Like the other codes, patient consent must be documented in the medical record, And some of these, unlike the others, are not telehealth eligible, but services can still be delivered via phone with secure messaging. Next slide, please. So to help providers understand and use these codes, CAPCT, along with the National Caregiver Support Collaborative and ATI Advisory, again with support from ACL and HHS, created 2 quick reference guides to facilitate billing of these codes that are structured as a quick algorithm to help providers very quickly identify the right billing code for their specific situation. And both of these guides were recently updated to reflect the calendar year 2026 physician fee schedule. So they are up to date. Next slide, please. So this is just a quick snapshot of what they look like. So it's hard to see, but there is an algorithm here to help you quickly get down to the appropriate code for your situation. And with that, I would say if you're interested in obtaining those guides, please scan this QR code or find us on this web address here underneath the QR code to access the billing guides, all of our training resources, and to reach out to us. So thank you for sticking with me, and I look forward to answering questions later. And with that, I will hand it over to Joshua.
Thank you, Josette. Next slide, please. And one more. Or 2. Yep, keep going. There we go. All right. Hi, everybody. My name is Josh Swire, Director of Safety and Quality here at the Michigan Health and Hospital Association Keystone Center. And I'm excited to share with you our new, well, it's not new, it's about 2 years old, but our Michigan Caregiver Navigation Toolkit, as well as a pilot that we did over the last 2 years with 2 hospitals here in Michigan. Next slide, please. So I'll perform an overview of the toolkit, which is available for you free. It's online. Please use it. We'll review the gap analysis tool that we created that drives programming. We'll evaluate outcomes from a large academic medical center in Southeast Michigan who piloted the toolkit over a 2-year implementation period, and we'll discuss next steps and hopes for expansion here in Michigan. Next slide. So quick history on the toolkit. During the height of the pandemic in 2021, we were actually approached by the funder of the Michigan Health Endowment Fund to start working with some of our hospitals here in Michigan and developing best practices on how to operationalize new caregiver programming in an acute care environment. So we spent about a year to a year and a half working with Henry Ford Health, Wayne State University, as well as Rush University to create a toolkit where a hospital could say, I don't even know where to start. How do I start and operationalize a program? Next slide, please. And briefly, before I continue, just want to define the caregiver because I know caregiver has several terms. Some hospitals refer to their nurses as caregivers, etc. A caregiver, for the sake of this presentation, is a relative, partner, friend, or neighbor that provides a broad range of assistance for an older person or an adult with a chronic or disabled condition. And typically, this is an unpaid role. Next slide, please. So while we were creating this toolkit, we really honed into the 7 domains of programming. So this is not all encompassing to all the areas of caregiving itself, but how does a hospital start from scratch and operationalize a new program? So starting with healthcare staff, do you have the dedicated support staff, whether it's social workers or nurses, to pilot the work? Assessments, choosing not only how do we assess the caregiver once we're identified, but how do I identify them? We here in Michigan, we do have the Michigan Caregiver Designation Act. So a lot of our hospital systems, if not all, already had a process in place on admission where we were asking if those folks did have a caregiver at home. So the identification of the caregiver in the pilot study was a little bit more easy because we've had that process in place for quite a few years here in Michigan. Community partnerships. We realize that hospitals and health systems cannot provide 100% of the solutions. Community-based organizations like your local areas of Agency on Aging, local health departments. There's lots of local programs out there that we would connect the hospital with, and we would create this big referral bucket. So once a caregiver was identified as high risk for burnout, or strain, we would then conduct an assessment with that person, give them individualized interventions based off of what is available in the community, and we also did a 60-day post follow-up reassessment to see if the interventions we put into place had an impact. Education was huge, not only education of the caregivers, but education of staff in the facility. What is this program? How do you refer to the program? Getting those subject matter experts on board so that the work is hardwired, and we know once we make a referral to like the social worker or the nurse that's overseeing this program, that they're giving the education to the caregiver that they need. Integration into systems, marketing referrals, and monitoring, evaluation, and sustainability. Next slide, please. So I know this is probably small for everybody, but this is a snapshot of the gap analysis split by domain. So you'll see on the left-hand side, there's healthcare staff assessments, etc. And we actually created the interventions from fundamental to advanced. So we built this gap assessment in our learning management system where the hospitals would go in, take their baseline assessment, and understand where they are currently in each of these interventions. And again, this gap assessment or gap analysis was created using other programs around the nation that have utilized these best practices. So, and a lot of it really is basic quality improvement. I mean, there's even things on here. Do you have a telephone set up that, someone can call and get a referral for? Is your EHR linked with an interface so that you can get referrals, things like that. So the whole point of this is that we would then essentially complete this gap analysis, and the LMS spits out a report and says, here's what you're doing, here's what you need to work on next. And then we just did good old QI action planning and, tried to address and close all of the gaps that we identified over a 2-year implementation period. Next slide, please. In retrospect, we only were able to do this over 2 years, and we saw great results, and I'm excited I'll actually share them with you here soon. But year 3, we found really was needed just to really hardwire those things that that either didn't get done or just haven't yet been built into everyday systems. So year 1 and 2 are very heavy on launching and implementation, where year 3 was maturation and sustainability. Next slide. So here's the exciting stuff. So we used, we don't really endorse a product, but for this pilot, we used the Archangel's CII, the Caregiver Intensity Index tool. And on admission, they would get a CII assessment, which is broken down by psychological domains, transportation, financial. There's several domains. And it scores them low risk, medium risk, high risk for burnout. And what we saw from admission to the program to 60 days post-discharge was pretty phenomenal improvement numbers. In their actual CII score, we saw a 54% improvement from admission to 60 days post-discharge. Their overall mental health impact score, 46% improvement. Average assessment driver score, so those things that drive burden and burnout. So higher is better, 70% improvement. And buffers, so those things that are like those the buffer between you being the caregiver and something that's going to lead to strain, burden, and burnout, 19% increase. And you can see down there on the right-hand side, or bottom right, there's a little graph that shows that for the more visual folks. Next slide. This is actually my favorite slide because this is showing from admission to discharge, and I'm going to focus here on the bottom right again. 21 folks on admission were in the high. They were high risk for burden, burnout, and strain. Now, we weren't able to contact or get a hold of all 113 in the pilot because some people didn't answer their phones, whatever reason. That went down to 1, 60 days post-discharge. 84 caregivers were in the moderate. That went down to 10, 60 days post-discharge. 8 were in low that would skyrocketed to 50. So this is good. I mean, we saw a complete flip from high to low as time passed. Now, kind of what Joan was mentioning in her discussion was there are probably many other factors into this. A being they're not in the hospital anymore. That in itself could be take you from high to low. But with the little data that we had, we saw this as a really good success. And what we ended up doing was actually pulling a control group to compare the 113 denominator that went through the program to a similar group that did not. And if we want to go to the next slide, I believe, yes. What we saw, one more, please. Yes, so what we actually saw was a decrease, an 11% decrease in ED visits per 100 patients. So we did see some immediate financial and good clinical outcomes, 11% decrease in ED visits. And we actually saw a decrease in readmissions 90 days post-discharge. There really wasn't a ton of 30-day, but when you think about it, I mean, the caregiving experience is not immediate. It is long-term relationship building. Even at Henry Ford, some of these folks stay on caseload, sometimes for 6 months or a year. This pilot really only looked for 60 days post-discharge, but we're very confident that we saw some very good outcomes, and we would love to continue to spread this. And like I said, this is a free toolkit. Anybody that is interested in meeting, talking about it, kind of going through this with a fine-tooth comb, please contact me. I'm more than happy to set some time aside. Next slide. Okay, and that's it for me. I'm going to go ahead and pass it back over to Yadira.
Great. Thank you, Joshua, and thank you all for your presentations and just sharing the incredible work that you all are advancing at your individual institutions across the country. And so I have had some time. Thank you for submitting your questions. Please continue to do so. So we'll get started with those. And the first one for you, Joanne, is in engaging with key stakeholders, what were the common challenges or barriers in defining an appropriate scope of service boundaries within the different department functions? So, for example, bedside clinical care may have different perspectives on the depth or the care of delivery in the scope of service versus a practice manager or RCM.
Great question. I think from the first time we met, this question came up and it continued to come up throughout the planning process. And I will say that when I started conceptualizing the idea of this program, I went to a lot of different leaders who said, we do this already. You don't really need a program. It's already within our scope of practice. I think once we got the right people in the room who really understood that this was going to be a caregiver-focused program and anything that had to do with patient care was really going to be passed on. So I think developing the scope of practice, and this became a big part of our training curriculum as well, is really identifying where those guardrails were and at what point did we move over the guardrail into the patient care side. So there was a lot of concern, and I think at the beginning there continued to be concern about whether we were overstepping and that this was potentially moving into the scope of practice for social workers and for care managers. And having said that, a program that's specifically focused only on caregivers and caregiver needs is unique. And I don't think that's a lot of time what happens in the clinical space. So a lot of times social workers are assessing caregiver needs because they're looking at discharge disposition and trying to figure out if caregivers can do things at home. And that is not what we were talking to caregivers about. We were really talking about the existential stress that they were experiencing at the time of the inpatient visit. And so I think as time went on, we learned more and more about how to deliver the message of what we were and what we weren't. But it is the one question that comes up all the time is, aren't we already doing this? And how do we know when we've overstepped boundaries into the other realm? our social work managers are really good at identifying what is patient care and what goes into the caregiver support program. So a lot of it was trial and error, but a lot of it got worked into our curriculum over time.
Thank you for that. And that's a really good segue for the next question around the CTS codes, and what they are in terms of providing training for the caregiver to provide care. And then your description just said of what the health assessments codes and the difference between those. So I'm going to roll two questions into one, and they're from the Q&A. And so the first question was, why are personal care aides or CNAs not able to train caregivers since they're already doing the bulk of this work? And then the second question that I'm going to roll on into is, how did CMS include these disciplines? So I see two questions. How do we get to the provider list of who's allowed to build those codes? And then there's this mention of who is doing the training, the education within the healthcare system. So if you can speak on that, that would be fantastic.
Oh, far be it for me to speak for CMS, but these are not unlike all the other Medicare billing codes in which are reserved for healthcare and licensed practitioners, which is physicians, nurse practitioners, physician assistants, certain types of rehab therapists. So it's consistent with the rest of who Medicare allows to use any billing codes, not just specific to caregivers. I absolutely agree that CNAs or personal aides or other people are the most qualified to be doing this training. No question about that. This is really just about, who can get reimbursed for it. And I have two thoughts. One is, I think one of the intents of the codes is to incentivize and raise awareness for the billing providers who are overseeing the overall plan of care to make the referrals and acknowledge who on the team is doing this and make the necessary referrals in the first place. And second of all, I think that there is some advocacy work to be done to try to help shape the CTS implementation to include expanding who is able to use these billing codes, such as CNAs and so forth, who can we include in the services delivered by trained professionals, whether or not they're licensed per se. So I think there's some advocacy that needs to be done to expand who can we include in that list.
Definitely. And I'm going to make a plug here because at NAC, we do some of that advocacy work in terms of when CMS releases its proposed changes to the physician fee schedule. So whoever asked this question, definitely encourage you to connect with us and other organizations who are looking at the CTS codes and ways to really improve the codes in terms of the providers who can bill and among other things. So just wanted to make that quick plug in. I have a question for you, Joshua, and it's, what feedback have you heard from hospitals or care teams using the toolkit that you didn't anticipate when it was first developed?
Yeah, something we didn't anticipate, but I think we should have anticipated was the integration into the electronic health record. Even getting it into the test environment proved to be a big challenge. Many hospitals have committees that it has to go through an extensive approval process. And some of our hospitals, were larger health systems and they had 15 to 20 locations. And if they changed it in one system, it affected all the systems. So unfortunately, we had to develop a lot of workarounds with, keeping internal documents, the also dreaded Excel spreadsheets and things like that, putting, patient safety work product on everything. And then I believe one of you had mentioned too that charting was also a barrier because we wouldn't chart the caregiver interactions in the patient chart because that is not necessarily appropriate. But I know some organizations that have opened a chart just for the caregiver. I'm not exactly sure how that works in the terms of, I don't know if that was opened in a non-billing perspective. I'm going to assume it was. So yeah, really the EHR and how to chart that interaction.
Gotcha. Thank you. And this next question could be um, answered by all of you or any one of you, but it's, did any of your interventions include assistance for caregivers navigating Medicare or Medicaid benefits access? Whoever wants to take it. I see you off mute. Go ahead, Jill.
I'll just take a stab at it. So I think that if this was to come up, the volunteers would contact our social work managers, and the social work managers would refer them to the financial services who, and I think that they've got a good relationship with them so that they could get them in and navigate that quite quickly and without a lot of hoops to jump through. So they would probably be the conduit between the caregiver and financial services to help navigate those services for the caregiver. That sounds like a circular way of saying it, but they would get them to the right people.
I agree. That's exactly what had happened through our pilot. I will say that we had this grand idea of creating a referral to the financial department, specifically through the emergency room. So ER being able to say, hey, they need Medicare, Medicaid, or eligible, see if they're eligible, get a referral. We turned it on a Thursday and it was turned off by Friday because they received such an influx of referrals that the financial department couldn't even keep up after 24 hours, which shines a light on a big problem, right? So great question. And I feel like that's something that really needs to be elaborated more on because, yeah, that was definitely, and we never solved it. You know, we didn't solve it during the pilot.
Gotcha. This next question, stay off mute, Joshua, because this next question is for you. And it is curious to hear what assessment tools you found most useful in identifying caregiver needs and making sure that those assessments were validated and published in peer-reviewed journals.
Yeah, so we were really flexible because this wasn't a research grant on allowing the hospital to choose the assessment that they felt that fit them the best. So each of the two actually had a full committee where it went through their CNO and went through their PNPC. So or not PNPC, their PFAC. So it had many layers of selection. We don't really endorse any specific tool, but there's a lot of good tools out there that are free for use that are peer reviewed and have been published. Like I believe the Modified Caregiver Strain Index might be one. And actually in the toolkit, there's a list of potential assessments that you could use. Again, and it's difficult well, it's not difficult, but we have to differentiate between the two assessments. The first assessment is, how do we identify that there's even a caregiver that I need to go see? And then once we identify the caregiver and the clinicians at the bedside, how do we identify their caregiver needs? And that second assessment seems to be the one that is more difficult to put your finger on and which one you want to select. So one hospital, like I said, they use the CII. It showed great improvement. I don't know if they're published or not, but I believe the other hospital used the Modified Caregiver Strain Index, and I believe that is a published practice. And we saw similar results in both. So,
Gotcha. Thank you. So, I want to, that wraps up our last question. Before I switch to my closing remarks, I do want to mention that the one question that was asked about Medicare reimbursement frameworks, I want to point to a paper that NAC released in collaboration with the Coalition to Transform Advanced Care, or CTAG. Focused on integrating family caregivers into healthcare systems and policy. It's a great paper. It's called Not Just Visitors. And so Lauren dropped the link there. So with that, I want to, Mike, can you pull up our last slide? I just want to thank all of the speakers for sharing your insights and the incredible work that you're doing on the ground. We will share the recording. We will include the links and that we've included in the chat in the post webinar follow-up. Thank you all for joining us today. Appreciate the questions, the engagement. And if there's one thing that you can take away from today is that supporting caregivers isn't separate from delivering high quality care. It's really essential to it. So I would want to recognize that. And finally, I want to recognize that this work would not be possible without our funders who are listed here in this slide. Thank you again to our speakers, to you all for joining us, and don't hesitate to reach out to our speakers and or NAC about our complex care collaboratives and the work that we are doing in this space. Have a great one. Thank you.